Dear ESTS members and webinar attendees, my name is Livin de Pipere, your moderator for today. This webinar is the 7th one of the 4th season of our ESTS educational webinars, and the subject today is impact of gender in lung cancer. I'm very glad to introduce you to a non-European thoracic surgeon from Boston today. Professor Yolonda Colson is the chief of the Division of Thoracic Surgery at the Massachusetts General Hospital, and she's professor of surgery at the Harvard Medical School. She's an incredible researcher with a focus on polymer and nanoparticle drug delivery aimed at preventing cancer recurrence and also sentinel lymph nodes in lung cancer. And one of her special clinical interests is understanding the unique differences between lung cancer in women. As you already know, we will ask your interactivity. So be ready to answer the poll questions, and please ask as many questions to the expert as you want in the questions bar. If you just want to say hi to each other, please use the chat. I would say enjoy the lecture, and Professor Colson, the stage is yours.
So first, I want to really say thank you for the invitation. I consider this to be quite an honor. ESTS is one of my favorite groups. You may or may not know. In about a month, I will be the president of the American Association for Thoracic Surgery, and I will actually be coming to visit at the ESTS. So I really look forward to getting to meet all of you and having that opportunity for our two societies to really kind of become really good friends. And so I have many great friends in the ESTS. So this is a very special opportunity for me. So thank you very much for the opportunity and for everyone's patience in getting this all together. It's a great opportunity. So I'm going to go ahead and start with just getting right to business and talk a little bit about this. That I think it's many of you may already know the magnitude of the problem. You all have familiarity with lung cancer, most likely, and that it is an enormous problem and a healthcare problem. Lung cancer particularly is a common problem, being over 2 million patients a year, but it's also deadly at 1.8 million a year. And I've kind of drawn this diagram of incidence versus mortality. And if you notice, they're fairly closely linked, which has been one of our major problems. And there's a lot of hope on the horizon that we can actually change that in the next, several years. But you can see that although the incidence it may vary from place to place, some of it is reporting, but the mortality seems to parallel our incidence pretty closely. The second thing is it is not just an isolated problem. There's variabilities. You can see the global lung cancer incidence of men versus women. And although men tend to have a higher incidence overall, it is not like it's isolated to just one place. There's hot spots in a lot of different places, and there's quite a bit of variability, and it is a global problem. I did pull some data looking at differences in incidence and mortality by men and women in Europe. And this is a nice study that's from the European Cancer Burden in 2020 in the European Journal of Cancer. And you can see, and if you look at the incidence, here you can see that breast cancer is the most common cancer in women and prostate in men, but lung is very close behind in men and is third in women. Unfortunately, the mortality is even more closely linked in that the mortality, it's the #1 cause of death in men in Europe overall. And it is the second leading cause of death in women. And there's not that much difference between breast and lung cancer mortality in Europe. And as you can see here, we're talking about almost 2 million people. So what's interesting, although it is the overall in Europe, it's the second leading cause of death. What percentage of European countries do you think lung cancer is actually the leading cause of death in women? And you can see there's a number of choices.
That's the question you can answer as the audience in the polls bar. Most of you already know this system and you can work with it. So you have the people and polls. There you can vote. I see that some of you already voted, but we are with much more people. So please give your vote. It's anonymous, so you cannot do anything wrong. It's just to have an idea.
It's a very interesting fact because we don't think about that, right?
Mm-hmm.
And how close that it really is to breast cancer. And in some places it will be actually more than breast cancer. Kind of looks like it's stabilizing out.
I think so, yes.
So the answer, very good, is it is actually a third of the cases, roughly a third of the countries. Lung cancer is actually the leading cause of death in women. And I think as our therapies get better and better in breast cancer, that number will rise unless we get better and better at lung cancer as well. So great. When you look at I've kind of shown you the mortality and incidence rate of men versus women of all of Europe. But when you start to actually break down the differences here in all the different countries, it's small to see it. It's more about looking at overall the pattern. And when you look at the pattern, you see that in general, the mortality parallels the incidence from incidence to mortality of men or of women. But if you'll notice, female incidence and mortality here is shown in purple, whereas men is shown in blue. But there's differences in both the incidence and mortality of women if you compare it to men, even within the same country. And there's differences between incidence and mortality of women among countries. And I think that's quite interesting because it tells us a couple of things. It tells us that there may be differences in the incidence and mortality based on just being a woman versus a man. But there's also differences if you're a woman in different countries, suggesting that there's differences in gender as well as sex. And I'm going to talk a little bit about what the difference of those two things are, so you can start to think about how complicated this issue actually is. So when we think about it, one thing that has been said is if you think about the sex of an individual, every cell has a sex. That helps determine body size or organs, drug metabolism, hormones, reproductive potential, the ability to have a pregnancy, menopause. If you're a female, you have X chromosome inactivation. Those things are more genetically involved in your risk. And so there is we do think there's probably some differences in genetically of susceptibility and a number of these things. But there's also differences in gender. Do women smoke in that country? Is there more exposure to smoke with cooking? Is there differences in radon exposure of men versus women or women between countries? So there's a number of gender things in being a woman in one environment versus another that probably alter risk and may alter what we see in terms of their presentation. And so as we go through some of these, we really haven't untangled many of these, but I think we're starting to think about what are actually the risk factors and what are inherent risks of having the X chromosome or hormones or whatever versus what is the risk depending on what your environment and customs are and exposures are. So one question is a true or false question. Are the majority of women diagnosed with lung cancer current smokers? True or false? And clearly this is going to be, as I said, dependent on kind of environment and customs and kind of different cultures. So I think this also varies from country to country. Very good. So yes, I think The majority of smokers are actually, or the majority of people, women diagnosed with lung cancer, are not current smokers at the time of their diagnosis. What we find is there are some changes in epidemiology and trends, and here you can see these are the number of lung cancer of cancer deaths in the United States anyway, proportionally. These are all lung cancer, and so in the United States, lung cancer is the #1 cancer killer of women, more than breast, ovarian, and uterine combined, actually, in our country. But if you look, the majority of them are past smokers. Most studies show roughly half of the women diagnosed with lung cancer smoked in the past. Fewer are currently smoking. But what is interesting is 15 to 20% of women with lung cancer are never smokers. And that's about 2 to 3 times the incidence of male never smokers in getting lung cancer. There are a couple other things that are trends. More women are diagnosed at a younger age, but they exhibit an better overall survival, and we'll talk about that a little later. There has been less change over time in the female death rates from lung cancer, but there's been a pretty marked decline in males, largely probably related to the decrease in smoking that they have had over the years. And there is an age-adjusted incidence is greater in men, so more men have lung cancer, except in the never smoking group. So we're going to kind of look at 3 different areas here, and we're going to look if lung cancer is different in women, looking at both risks and susceptibility, and look at areas of detection and diagnosis and how they present a little differently, and treatment and outcomes. And these are somewhat generalities. It's not like we don't see women who have very similar presentations and diagnoses as men, but I think there is some patterns that you should be aware of that can maybe increase your suspicion in some cases. So in looking at risk and susceptibility, there's about 4 different areas that there seems to be some differences in women. And one is smoking versus non-smoking, which we've kind of hinted at already. There are some biological differences in actually looking at how women metabolize drugs. There's some environmental and occupational exposure, which again will be related to gender, and then some medical risks with radiation exposure or hormonal factors. So if we look at smoking in lung cancer, you can see that smoking is the #1 risk factor for both men and women. But there has been a lot of controversy and discussion depending on various different clinical studies, mostly being kind of retrospective, looking at them. Are women at greater risk if they smoke with less exposure? There's been studies that have said yes, studies that have said no, studies that may see women have it but haven't truly controlled for smoking risk. And I think that's really made it difficult. You can see over time, though, that male smoking, the prevalence of current smoking at the time of their diagnosis has declined quite a bit over the last 20 years in men. And women have also declined, but probably it's a much smaller number. And so we see less impact of that. What is interesting is women, if you look at deaths due to secondhand smoking exposure, so working in a nightclub, working as a waitress, women who are flight attendants, those types of secondhand exposures or secondhand exposure to smoking, now that there's less smoking on airplanes, but the number of women disproportionately seems to be women that have that secondhand exposure risk, largely because of occupations or doing, there's been discussion about smoking from fires or things like that. And so about 64% of deaths attributed to secondhand smoke exposure are thought to be in women. In the United States, we have a problem with female adolescents being some of the fastest growing groups of US smokers, and they tend to be more often will try e-cigarettes. And there's been a lot of interest in that. We don't know exactly what the impact is, but it is quite interesting when you look at our studies here showing that 12th grade, which is just before they go to college, The cigarette use has declined quite precipitously in the last 20 years, but we've seen since about 2011 a pretty marked increase in the use of e-cigarettes. And so I think we know that there's always a lag between exposure and what we see as the incidence of lung cancer. We saw that delay in women starting to smoke, that we saw the incidence of lung cancer peak later. And I think it's going to be very interesting for us to figure out what the ramifications of this are, and will we see differences in women because of their incidence in e-cigarette smoking. It's more acceptable in our country for the e-cigarettes than the smoking. Having said that, there's some very female-specific barriers to smoking cessation. What has worked in men has not always worked in women, and some of it is society-based, and some of it has to do with biologic differences. And I think they are important to think about if you are talking to a patient about smoking cessation, to figure out what the real drivers are or what has been the problem in helping them stop smoking. The fear of weight gain is a significant one. A lot of women will smoke in order to keep weight off or to prevent them from eating. And so that has been one of the society barriers. Having said that, it's quite interesting because they have an increased nicotine metabolism. And there has been studies to suggest that women will have increased symptom withdrawal compared to men when they do studies asking them to mark down what symptoms that they're having after they've stopped smoking. They also tend to be less compliant with nicotine replacement therapy in this same study, but the withdrawal symptoms seem to be worse, even accounting for that. The other reason that women will often have difficulties in stopping smoking is they tend to use smoking more to relieve stress and anxiety, whereas at least in the United States, there was a big driver that you were cool by smoking and you were the, cowboy out on the range and you had your cigarette. And as that became less and less cool, the social drivers to do that tended to go away, whereas women, the social drivers tends to be weight gain or to deal with stress and anxiety. So they're harder to change that. And it's still seen often as a independent woman smoking, being a kind of a rebel that's still seen in some circles as to be a sought after kind of identity. There's also differences in that there can be some differences in success of stopping smoking varying with the menstrual cycle, in that increasing stress or anxiety can make it more difficult to stop. And so you can have them try to stop smoking at different times. Either after their menstrual cycle is probably a little easier than at the beginning of the menstrual cycle. There's also this kind of increased dependence. There's been data to suggest that if there's social support and you link women into a group of other people that are trying to stop smoking, or their spouse is, that they will be more successful in that type of a supportive environment. It's very difficult if the spouse is smoking for the woman to stop smoking, because there's a whole number of interactions and relationships that make that difficult for them to not smoke. So those are things that you're talking about smoking cessation that are largely societal based, but it probably also leads into some of the nicotine metabolism questions. Okay. If you see something in the chat, let me know. I'm watching the poll.
Okay, I'll let you know.
There is, among never smokers, there is this bias, gender bias, in the fact that if you look globally, roughly 15% of all types of lung cancer in men can be in non-smokers. And depending globally where you are, if you average out, almost half of the women are thought to be not directly attributable to smoking. And that largely has to do with a very high predominance of adenocarcinoma in non-smoking women in Asian countries. And I think that is an interesting thing that I'll show you at least some of the differences genetically in that population. If you have a never smoker who has lung cancer, the most common type is adenocarcinoma, which I expect most of you know, and we'll talk a little bit about the subtypes and what we see in that group. Additional risk factors that have impact on kind of some of women, particularly that are thought to be non-smokers. The work and environment, 23% or so are attributed to radon, which we have areas of hot spots in the United States where it tends to be if people are down in working down the basement or non-ventilated places. In the old days, we used to think about people washing clothes down in the basement or somewhere where they're exposed. We now test for radon in many areas, and we'll actually vent the basement to try to decrease this risk. But I have had patients who have tested their house for radon when they went to move and then found out they've been living in their house that had high levels of radon. And actually that prompted getting a CT scan where we found lung cancer in a complete non-smoker. Secondhand smoke, we talked about being jobs, that many of the occupations that women will typically have can have higher smoking, secondhand smoke exposures, or radiation exposures, as with flight attendants. And we have a pretty active group of flight attendants that does a fair amount of research and supports research into lung cancer. Medical exposure, particularly in the past, radiation therapy for breast cancers, hormone therapies. There's been a lot of question about, are they helpful or not hurting? The jury's out a little bit, but we'll talk a little bit about those. And then the questions about marijuana and e-cigarettes, and do we know what their cancer risks really are? But all of those are probably playing a role in women. I talked a little about what's kind of thought about the biologic susceptibility and perhaps how being a female can increase your risk. There is data to suggest that there is probably some decrease in the carcinogen clearance in women, in that in your ability to detox certain carcinogens, and there's some alterations in the P450 pathways that can make it a little harder for women to clear carcinogens. And that's led to some increase in the DNA adducts, and I have different things written here, how the DNA segment's bound to carcinogen, it decreases the DNA repair, and they particularly see that in smokers, that there's higher adduct levels and increased adducts in women with lung cancer. There's no direct cause and effect relationship, but it is an interesting observation that we do see some of these things that may make women more susceptible to maybe lower levels of smoking. And then there's some increases in gene mutations, P53, RAS. You're going to see increased KRAS mutations in smokers, increased P53 mutations seem to be seen in females, and we'll talk about EGFR, particularly in non-smoking women. And we feel these probably increase the risk of lung cancer, but it's been very hard to prove that in any of our trials. So one of the things that's been talked about is estrogens, and there's been a lot of discussion that estrogen receptor beta is overexpressed in 60 to 80% of lung cancers. So therefore, is it that the hormone replacement therapy increases the incidence of lung cancer? Is there such data to show that? Is there data to show that anti-estrogens decrease the risk of lung cancer recurrence? Is there data to suggest that anti-estrogen therapy has been proven to decrease lung cancer mortality in randomized phase 3 clinical trials? Or is there no data on any of these to answer that question? You guys were getting too good on the other one, so I had to make one harder. And you will get these questions a lot in patients because that's one of their concerns, and there's been lots of data out published.
For more people to vote. please give your vote. It's more interesting for everyone to see what the audience think.
And what data people see and read.
In the meanwhile, if you have questions, you can ask them in the questions bar as well. Okay, we have a bit more votes now.
Yeah, and this one's particularly hard. So, and I'll talk about this data. What we know right now is essentially we do not know data on any of those others. Right now, we know that the estrogen receptor is overexpressed. We don't know the clinical implications exactly of that. And I'll talk about the data and how it's mixed. And it's important just because patients will come and have one or two studies. So there's been about 13 studies, including 4 meta-analyses, where they looked at the Women's Health Initiative. There was an EAGLE study, the Nurses' Health Study, which you may or may not know is where they essentially have followed nurses over much of their lifespan, and they fill these very detailed questions of what happened to them in the last year. And they started out looking at this largely with their health and breast cancer, and then they've started to kind of now look at what other things have shown up. And they've not found a definite increase or decrease in risk, incidence, or mortality of lung cancer due to the hormone replacement therapy or oral contraceptive use. In those studies that they have. In general, what we've tended to recommend is if you don't need those, to not use them. It decreases other risks as well. We don't think they're good for lung cancer, but we have not seen a definitive thing to tell someone that they should not use them for that reason. What seems to be the bigger health intervention is if they're smoking and on those, they have significant other health risks. And by smoking is actually probably the most important thing to decrease their lung cancer risk, is to get them to stop smoking more so than stopping their hormone replacement therapy. What is interesting is there's been several interesting trials. They are not clinical phase 3 trials, but they've been large population-based studies that almost all of them were started out where anti-estrogens were being used for treatment of breast cancer. And as they followed them with these long-term treatments, what they noticed in several of the studies was that they thought they saw a decrease from expected in the lung cancer mortality. So this was probably one of the most famous ones was the Geneva Cancer Registry, but there's been additional ones in Manitoba and the Taiwan National Health Insurance Database, where they were looking at breast cancer survivors that were also on these drugs, usually tamoxifen, and they did not see a change in the incidence. They still had lung cancers, but they did seem to see a decrease in the mortality. And so there has been a lot of speculation about this. People have not necessarily been able to do that, and it's pretty hard to do a randomized phase 3 clinical trial in it or to do prospective data. But I think that's one of the questions, and I actually searched all the last couple weeks trying to find any of these trials, and the data is just not out yet. There is also some discussion about if these antiestrogens reduce lung cancer incidence, and that's been varied. So there's been 15,000 women that have been followed in about 14 of these ECOG studies that have been on tamoxifen, and they haven't seen a decrease in a second primary lung cancer or a lung cancer appearing. But in the Taiwan National Health Insurance, they did think that they saw a statistically significant decrease in lung cancer incidence in patients who were using antiestrogens when they were younger for their breast cancer treatment. And so now this has spurned about 10 clinical trials, which are all trying to figure out this relationship between estrogens, antiestrogens, and non-small cell lung cancer. So I would keep tuned to that. I think keeping our eyes out on that and looking for what those differences are over time and what the impact is. Okay, there has been some new data looking at antiestrogens in combination with other types of treatment in lung cancer, also trying to see if it can improve outcomes in treatment of lung cancers. And those are also somewhat variable, and final data is not out yet. So there will be a lot in this space. We just have to see what happens. Okay. So that's kind of the risks and susceptibility. And so a lot of it we don't know. We know some things, we don't understand them, but we know that there's probably some differences, and there's some large trials that are really trying to outline a large amount of risks and what's different between men and women and what their exposures are and not. There is some discussion that women, if you look at women who get lung cancer, they tend to have probably fewer pack-year history of smoking, and they may have smoked less, overall less, or shorter periods of time. And that becomes important when we talk about lung cancer screening. So we talk about detection and diagnosis here. I'm going to talk a little bit about what we're looking for in women with lung cancer. The first is actually really interesting in thinking about lung cancer screening overall. 76% of eligible women in the US anyway receive mammograms. What percentage of women who meet the criteria for lung cancer screening actually get lung cancer screening performed? This data is from the United States. I don't know what it is all over Europe. That data is too hard for me to find because it varies quite widely. Again, a very smart group, which is really helpful. So, as would be, as you have mentioned, see if I can move it to the next slide there. It's less than 10% of women who are actually eligible for lung cancer screening actually undergo lung cancer screening. It's one of the major problems in our country, in that we aren't getting people to get it, even though we have a way that it is approved and we can do it. And it's between 50 and 80 years of age that have a 20 pack year history of smoking. What is interesting is we've just redone those criteria specifically because what we realized was we were missing a fair number of women who ended up cancer did not qualify. And so what are the gender differences in screening? Roughly half of women who are diagnosed with lung cancer in our country anyway don't actually meet our screening criteria. They either have a lower pack year history of smoking, or they're younger or older, or they're not smokers at all. So we are really working on trying to come up with ways of how do we identify who those women are, given that a significant number of them will have stopped many years ago. So if they've stopped in the last 20, 30 years, they wouldn't qualify, or 15 years ago, they don't qualify. And so if they've stopped many years ago, or they're not a smoker, or they had low smoking exposure, they don't qualify, but we know that they can still get lung cancer. Only roughly 6% of women who are eligible by the guidelines actually undergo lung cancer screening. And so we have a lot of work to do in our country in getting women to do that. And it is a very big stigma to get people to want to do that. I think showing that we have survivors is going to help with that, the stigma of the disease. And I'll be interested afterwards to hear your guys' thoughts on what you see in terms of stigma. The screening decreased death in women, as you all know, probably even better than us, in the Nelson trial. It's thought that screening decreased mortality in women by 33% and 24% in men. And that's probably due to the fact that you're getting more of these peripheral adenocarcinomas. They tend to be a little slower growing. And so you probably catch them earlier. And we'll talk a little bit about gender differences in histology. And then we have our new guidelines here, actually by changing to be a little younger, lower risk of smoking history, has resulted in increased eligibility for women by almost double, 96%. I think most of you know the changing look of lung cancer, particularly in women. We see these ground glass opacities, which are hard to see. They're non-specific. They tend to be They can have a part solid component to them, which makes us more concerned that there is at least some minimally invasive adenocarcinoma. But women are about 50% more likely to have these ground glass opacities, which could be benign or malignant. And they often will have multiple ground glass opacities as well, making the management of these challenging. Just a little bit about ground glass opacities. The growth and solid transformation suggests malignancy, but they need longer follow-up. Biopsy and intraoperative localization could be difficult because they're hard to find. And many of these are quite indolent. If you look at them of ground glass opacities, the majority of them don't grow. And so you have to identify the ones that are actually cancers and then try to figure out how you localize them. And I'm not going to spend time talking about that, but understand that women have an increased likelihood of having ground glass opacities, and then the fact that cancers can look like them. If we look at histology, kind of just briefly giving you some ideas of what this looks like, men overall tend to have higher levels of squamous cell. Women tend to have higher levels of adenocarcinoma overall. And you can see over time, women have had increasing amounts of adenocarcinoma, whereas men in the most recent decades have been fairly flat, but decreased in squamous. And women have not really increased in squamous cell. They've been relatively constant and flat. What is interesting, in non-smoking women have 1.5 to 3 times the incidence of adenocarcinoma than non-smoking men. And I think that that is what we see in this group, in this population. If we look at the genetics, you can see squamous cell, the genetics that we see within squamous cell versus adenocarcinoma, in that we have a higher incidence of KRAS and EGFR, but 60% of tumors with ground glass appearance that are adenocarcinomas actually harbor an EGFR mutation overall. We can actually, if you look at genetic mutations increased in lung cancers in non-smokers, what do you think the most likely one of that is? Correct. This is pretty, in non-smokers, overall KRAS can be high in smokers together, but EGFR is the most common one in female non-smokers where you see a mutation. And here you can see just the difference between females and males. If you look at non-small cell, what you see is KRAS is pretty prominent in men and women, but what you see is this difference in EGFR proportionately tends to be in women, particularly the EGFR exon 19 mutation, whereas the L858R mutation tends to be more common in men. There's a few others that also are slightly increased in women, but EGFR kind of is what started much of our interest in women's lung cancer, in that they did have this disproportionate difference. And then what you'll see is that here is what you see in Asian and the influence of Asian heritage and smoking. And that if you look at never smokers versus never smokers here versus former or current smokers here, you'll see that the never smokers have a large proportion of EGFR, particularly if they're Asian, less so if they're non-Asian, in terms of what they see as genetic mutations. But we tend not to see nearly as much if they're former smokers, non-Asian, or non-Asian current smokers. There, KRAS tends to become more predominant. And so that's quite a difference, particularly given that there is therapeutic benefit to knowing some of these mutations. And so we often will, now we do mutation analysis, particularly if we have never smokers, looking for what the mutation history looks like, because it'll be very different. So last is really looking at kind of the treatments and outcomes. And there's a variety of different mutations that I know you all look at, and I'm not going to talk about all of them. I'm going to focus mostly on ones that I think have some genetic differences, and will allow you to think about a kind of what to look for and how to do that. I've already mentioned the EGFR mutations. Most of the EGFR mutations are found in non-small cell lung cancer adenocarcinomas. It's rare to find them elsewhere, but they do tend to be women, never smokers, younger age, and East Asians tend to be predominantly the ones that have this or at the highest level. And what's interesting is that about 10% of female smokers will have the mutation, but about half of female never smokers, even when you're not looking at the complete Asian difference. It's got several drugs, as you already know, that can treat these, the tyrosine kinase inhibitors. And this is particularly important if we have multifocal disease or metastatic disease, obviously. The therapeutic response correlates with the presence of the mutation, which is why we tend to try to sequence them. You get about a 70% response rate, at least in some of the earlier trials, with the mutation, whereas 10 to 20% without. So we tend to look for them and look for the mutation. And there's an increase in improvement in the progression-free survival. They tend to be able to, they do develop resistance and can move to a different one of the tyrosine kinase inhibitors. And that's a lecture for a whole nother time about how to manage these tyrosine kinase inhibitors. But the best response tends to be women, adenocarcinoma, non-smokers, and East Asian, and can be quite amazing. You can go from, bilateral, both lungs, very involved, to actually very nice responses for quite a while. And then they tend to develop resistance, as I said, after a few years. KRAS is the other one that's quite common, and you can see it's 50 to 30% of these non-small cell adenocarcinomas, but it tends to be smokers. And we tend to think of as EGFR and KRAS as being mutually exclusive. And so there's a slight predominance in men overall. But I brought this in here because the KRAS G12C mutation tends to be more frequent in younger women and may have a lower smoking history. And now there are agents to try to target that. So it is worth looking at these KRAS and look for your G12C mutations. They tend to have an overall poor prognosis and have been harder to treat. But with this new agent, I think we're going to see a big shift in treating these. The ROS1 mutation you may or may not have heard about. I bring it up only to talk about the fact that there is crizotinib tends to be effective for these, at least at the initial responses for these. There are ROS positive non-small cell lung cancers, and they tend to be more common in women. Crizotinib crosses with ELM4 ALK, but that doesn't seem to be more common in women. And the last is PD-1, PD-L1, just because you may get questions about immune therapy from patients. The only reason that I bring it up is that the best responses tend to be in men, smokers, squamous histology, but chemotherapy plus pembro may actually be better in women, and that there is some discussion about how immune therapy is working in women versus men, and the expression of antigen or not antigen, and the PD-1 or not. And there's been a couple trials out, or at least studies out, talking about that, and that the chemotherapy may make pembro work a little bit better. And I think we're going to see what happens with that in the coming trials. So stage for stage, which non-small cell lung cancer patients tend to exhibit better survival? Men, women, or they're equal? Correct. In general, women tend to do better if you match them stage for stage. So when they look at the data and you look at 5-year survival for women versus men in at least our large SEER database, is the large database for the United States. There's about 55,000 patients they looked at that underwent surgical treatment for lung cancer. And when they looked at it, the difference was statistically significant that women did better than men when they matched stage for stage at about 62 versus 53. And if you look at superior postoperative outcomes, looking at complications, lower in-hospital mortality or 30-day mortality, and they had fewer postoperative complications. That's probably due to the fact that they're a little younger, and in general, women tend to have fewer comorbidities than men in our country to start with. But there's maybe differences as well in terms of how aggressive their lung cancers are, and these differences in the adenocarcinomas that they tend to get. I think in summary, lung cancer in women seems to be different in a couple different areas, and it does have some treatment implications or how you approach them. There's probably more non and never smokers with lung cancer that are women. So if you hear that they're not a smoker, it becomes really important. If they have histories of bronchitis, a lot of my patients tell me they've had bronchitis for a long time. Their mother may have had it. And the problem is they don't meet the standard criteria for lung cancer screening. So you have to have a little bit of a low threshold to try to think about what it is. And hopefully we will learn more about other risk factors that make us kind of pique our ears a little bit to say what's going on with this person. So if you see a ground glass opacity, you have a real possibility that the ground glass opacity in a woman, if she's a non-smoker, doesn't mean it's not a lung cancer. And then think about EGFR mutations and what you need to do in women. Think about targeted therapies, and we may find anti-estrogen therapies play a role in the future. The big message to get out to all patients is that the lung cancer is treatable and curable, particularly when it's found early. And those that are late, we now have far more agents. And I think that really helps us to motivate patients to seek treatment and to advocate for themselves and their family. And that's all I have. Good job on the questions, guys.
Indeed, the questions are, thank you very much for this very interesting topic, something completely different that we're not really used to. And I learned already a lot on complexity and difference between sex and gender, for instance. But let's go first to some questions. First question, in an interesting Taiwanese study reported that female non-smokers with lung cancer had a particularly high prevalence of infection with HPV oncogenic variants. Can you comment on any viral association with lung cancer susceptibility, in women?
I think there's been a lot of discussion about that. I think there have been these associations. I don't know that we've really been able to completely causally link those. And I think that's one of the areas that are kind of quite interesting in looking at. There's been a lot of speculation with some of the COVID vaccines. Are we going to see changes in that? People that had injury. There's been a lot of discussion that injury overall to the lung, there is some data to argue that women have different cytokines and different responses to injury overall in their lungs, which is going to be quite interesting in one of the areas we're starting to study, with an idea of, does that have something to do with their susceptibility when they're not smokers? And I think the viral associations are going to come out of that data.
Mm-hmm. Another question is on the survival in women. Is this overall survival or disease-specific survival, since you can expect more comorbidity related to smoking in men?
So I've seen studies with both. The overall survival clearly, I think, is complicated by the fact that we have more comorbidities and men that have smoked. They've tended to smoke longer. They've tended to smoke more. When they have tried to correct for that, they still can have a better survival in women. There's also data that suggests that the disease-specific survival is also better. And that has varied quite widely by which population you're looking at. So, for example, if you're looking at populations that tend to be non-smokers that are getting more of these adenocarcinomas that can often be quite indolent and take years to actually grow and develop. Clearly, they do better on a disease-specific survival, particularly now that we have agents that we can treat them with some of these EGFR inhibitors. And so I think we're seeing that in general, women do better, but I think the reasons could be different for the disease-specific versus the overall.
Okay. Another question: in female patient with lung cancer, which mutation panel do you or does your oncologist check in your clinical practice? Is there a difference with men or not yet?
It's not so much standardized across all institutions in the United States, and there are kind of set panels. I would say that it is personalized to some degree, in the sense that if I have a male who has a high smoking history, the likelihood of testing for EGFR mutations, we don't always do. Because especially if they, in our country, have to pay for insurance-wise, it's a large expense with a very low likelihood. But if I have an Asian woman who's a non-smoker, I'm going to get that test, but probably will not do KRAS. So we do tend to personalize it based on kind of what we think the most likelihood, and also what we have as agents to treat, right? Okay. So that's probably the best way to think about that.
Okay, and another question on the surgical side. Is there any difference in operation time and in hospital stay? I think you already mentioned hospital stay.
So I think it depends a little bit on what the comorbidities are. I don't know that I could particularly say match. I don't think there's been studies that have matched for all of that to say. I think there's studies that may talk about women versus men, and I think it depends on the hospital. I think it depends on insurance. It depends on so many things. I don't quite know that we can answer that just from a gender perspective. Okay.
Okay. Next question. There are some studies that women have a higher risk of intraoperative complications, especially if surgery is performed by a male surgeon. You mentioned a low rate of postoperative complication, but could you comment on this? And indeed, these were some studies that came out earlier this year in JAMA Surgery.
And it's a very interesting paper that came out talking that women had less complications and did better if women surgeons were matched to female patients. It didn't seem to matter as much as I recall if males were matched to males, but it had more to do that the women patients benefited. And there's a lot of discussion about why that could be. Does it have to do with, different discussions? Does it have to do with different risk factors? It's unclear to me what that data means yet. And I think it spawns a lot of discussion about what should we look at and what are the factors to look at. I think right now at the level that they have, I don't know that I can explain exactly why that is. There is some discussion that, especially in complex things, women's airways are smaller. Women tend to have a higher incidence of AFib. Are there other things that are contributing to that? And I'm interested in other people's thoughts about what they think could be relating to that. I mean, I don't have the answer to that one. I saw the data. I just don't know what to do with it yet. Okay.
We have talked about hormones and the effect on lung cancer. What about data on childbirth? Just comparing it to breast cancer. I think, can you say something on the age of the first childbirth and number of children? Is that important?
I think it's somewhat mixed data, like the hormone data is. There's been some studies that I think have argued that there may be some differences. I think it's often not captured in a lot of data and a lot of studies. And I think we've actually just started now to try to get in so that we could actually go back and look at actual childbirth and what type of oral contraceptive and those sorts of things, because that hasn't been typically followed for lung cancer, particularly because it's not usually that age group. And so we may ask if they've had children or not, but most people haven't recorded how old they are. And so there's been a lot of speculation about that, but I haven't seen a true definitive study to answer that question. But it's a great question. It's absolutely a great question.
Okay, the answer will come in the next years then.
Yeah,
we hope, at least. Do you discuss the female cases differently in your board because they have a better outcome? Do you go for more extended surgery, or do you treat them in a different way? That's the next question.
I think that when we talk about them, we will often, especially if it's multifocal disease, we do tend to think about that they have a ground glass opacity, and we will talk with kind of back and forth and say, do we locally control that? Even though we know that there's another site, we think it's growing slower. We will often maybe, manage that disease a little differently, because we know the one on the other side is suspicious for one, but we may locally treat one. We don't automatically think, oh, they have disease in another site and not do it. So I do think we tend to be a little more aggressive. And so I just had a lady the other day that we know both sides, both look like they had a lesion, and I basically did both sides. Because when we stage them, it doesn't tend to be in the nodes. And so do you treat them as two local primaries, even though they tend to have multifocal disease? It behaves as a slightly different disease. Whereas if, typically you saw people with two lesions, you would often think, oh, it must be metastatic. And here there's a whole group of these patients. It's not metastatic. They just have multifocal, but it's kind of like separate sites of disease that are seen to be independent. And so we do tend to use surgery, I guess I would say, more than just go to thinking that they have multiple sites. Does that kind of answer that question, I hope?
I think so. That's interesting to see indeed that you're looking at the patients differently, and also treating them differently.
Yeah, just because they come and you see them and they have a couple sites of disease, it doesn't necessarily mean it's growing quickly.
Mm-hmm.
It doesn't necessarily mean that you can't actually give them local control of those areas and not have to put them on systemic, because they really don't have other sites of disease outside of those two. It's a very interesting pattern that we've seen in some of these women who are non-smokers, otherwise healthy, and they may have two ground glass opacities, but they're not related to each other.
Okay. It's already a 1 hour webinar right now, so I think we can go to some conclusions. Today was a great webinar to me, I think for the rest of the audience as well. We had over 80 live attendees, and many other people will look to the replay, I guess. We had many interactions. Thank you to the audience for answering all these questions, and most of you did it very good. To me, it were quite difficult questions, so congratulations to the audience. On behalf of the ESTS Learning Affairs Committee, I would like to thank you, Professor Colson, for this excellent webinar today. And again, the audience for your interest and interaction. We hope to see you again next month for the last webinar of this season on intraoperative electromagnetic navigation with Marcelo Jimenez from Salamanca, Spain. So I hope to see you next month. And afterwards, of course, we will all see each other in Den Haag during the conference, I guess. Thank you again, and see you next time.
And I'm looking forward to seeing you all there. Come say hi.
Okay.
Okay.
Bye.
Bye. Thank you. This has been terrific. Just terrific.